much. Hi, I'm Dr. Kazemi from Bethesda, Maryland, just outside of D.C. Thank you to Vumedi for the invitation, as well as our audience tonight for joining us. So CT-guided planning, as we talked about, is nothing really new. It's been in practice for several years. And what I hope to focus on the next 20 minutes is really discussing some experiences of how we can make our treatments safer and more predictable. So when we talk about safety, we're talking about mostly anatomical variations, such as the nerve, the sinus, the other teeth, as well as any bony undercuts, as well as the bony interface with the implant. And when it comes to predictability, we're talking about four main regions: aesthetics, function, hygiene, as well as the longevity of the treatment. So basically, if you break it up into three segments, this is where CBCT or CT-guided planning comes into help: diagnosis, planning, and also guiding our implant placement. So during the diagnostic phase, we have questions. Questions like, do we have enough bone? Where are the vital structures? And what is the position and the condition of the adjacent teeth? So if you look at one of the most obvious benefits of scan is looking at the bone architecture and the bone anatomy. Here's the patient who was involved in a car accident and lost a number of lower anterior teeth. At first glance, the ridge seems to be fairly reasonable until we take a scan and we note that there is a significant defect on the buccal plate. So we did the scan using a radiographic guide in order to have a relative sort of look at where the bone is, how much is the defect that we're dealing with, and where is the ultimate teeth that eventually will be restored. How does that relate to the underlying structures? So this is an important information that we get in the diagnostic phase. Another critical piece of information is the position of the canal, the inferior alveolar nerve. And we have patients that have lost significant height of bone. Here's the patient that is treatment planned for 2 implants, number sites 30 and 31, has lost some height of bone and has about 8 millimeters of bone from the crest all the way to the canal. So we have to think about what type of implant can be used here. And we choose a wide and a short implant since we have plenty of width. This was an implant that's 7 millimeters in length and 7 millimeters in width. And you can see that it's crucial that we position the implant with maybe just a half a millimeter or a millimeter away from the canal. So this information is crucial to be able to provide this treatment safely and avoid any nerve injuries. Another important piece of information we get is preventing or avoiding what I call overcautiousness. Overcautiousness and misplanning. And here's a patient that had 3 implants done, and the dentist that placed the implants wanted to be too careful about the proximity of the nerve. So the implants that were chosen were not only short, but also placed above the crestal region. Ultimately, these implants were deemed to be ineffective. The surface was exposed, and as the cross-section shows, they were in poor alignment. And we have plenty of bone from the canal indicated by the yellow area and the crestal bone, so there's no reason not to take advantage of it. And here's the second implant. Ultimately, these implants had to be removed. The site had to be grafted and prepared for a new implant. Another key information from a diagnostic standpoint is the maxillary sinus, where we can measure the available height of bone in the posterior maxilla. This can range anywhere from the second premolar to the first and second molars, of course. And from here, we can assess the height of the bone that's available, and that is going to kind of direct us into thinking what mode of treatment we're going to offer. Are we going to use a short implant, perhaps, in a patient like this that has about 9 millimeters of bone? Are we going to consider doing an internal sinus lift to perhaps position a 10 millimeter or 11.5 millimeter implant? Are we going to do a standard or a conventional sinus lift to position a 13 millimeter implant? And also to give us an idea whether we're going to do the sinus lift and the implant in one stage or two stages. Typically, the guideline that I use is if I have any less than 4 or 5 millimeters of native bone, I do a two-stage procedure, augment the sinus, and then come back for the implant placement 6 months later. Another diagnostic or key diagnostic information is when we have adjacent teeth to worry about. Here's a patient with congenitally missing lateral teeth. We have about 5 millimeters incidentally. So we're going to do a scan and assess the available space. It's not unusual that patients having done orthodontic treatment and maybe the space has been preserved, there might be a convergence of the incisor and the canine. I apologize, I'm getting a little double echo here. Give me 1 second. Okay, I'm going to continue without the headphone. Hopefully the echo won't be there. So we're going to take a little closer look, and we see that if we place a 3 millimeter implant in the given space, that we have quite space between the teeth and the surface of the implant. And if we look at the proper dimension that we're looking for, and this is some of the studies that have been cited and described by Dr. Tarnow and Dr. Salama and others about achieving predictable papilla, we know that when we have a tooth-to-implant situation, we need at least 1.5 millimeters distance between the structures. And so with our prediction and the diagnostics, we can be certain that we can place a 3 millimeter implant safely. From our three-dimensional workup, we'll create a tooth-borne surgical guide to delineate our exact plan. We place the implants, and we have adequate space between the implant and the teeth, as well as the crestal bone, which will be extremely important in the preservation of the papilla and the soft tissue, and ultimately the aesthetic and the functional result. Diagnostically speaking, we also have various anatomical anomalies that if we don't know about or if we do not address can become quite problematic. So here's the patient that was treatment planned for implant number 18. Seems to have quite an adequate vertical height of bone as well as width. And as we look at the cross-section, we notice that there is an exaggerated undercut at the lingual plate, at the submandibular space region. So if we sort of glance at, how we would position our implant, we can certainly place the implant safely and avoid the perforation on the lingual aspect. And very obvious that perhaps a 5 or 10 degree difference from this can easily result in a perforation in the lingual plate. But we also have to think about not only the bone and the undercut, but also where is the restoration going to be? We need to negotiate between the available bone and the anatomical restriction as well as the restoration. That is ultimately the most important thing. So when we start to look at the scan and evaluate the position of the implant, we come up with a position of an implant that seems to be lingualized and not aligned with the central fossa. And we chose to do this in order to keep the implant in the bone and avoid that lingual perforation. If we move the implant toward the buccal and make it more aligned with the occlusion, then we will have a perforation through the lingual plate. So now that we know this, and the restorative dentist and myself, I know the limitations, we're going to place the implant in this position, realizing that we're going to correct it using a customized abutment and ultimately put the restoration exactly where we want. So this is with a plan and intention. So we're going to duplicate that into a tooth-borne surgical guide, and this guide will provide us with the exact trajectory and the angle as planned on our three-dimensional drawing. This guide is a 2.3 millimeter sleeve, which does not allow the surgeon to deviate from exactly what was planned. Again, even a 5 to 10 degree deviation can cause problems with the lingual perforation of the bone. So here's the guiding pin in place and the implant in position. This was allowed to integrate for about 3 months, ultimately restored with customized abutments and a crown, and we can see the second molar restored, number 18. Here's another view, and again the corrected customized abutments with the proper alignment of the crown. The next sort of reason why we use the CT-guided planning or CT-guided approach is in the planning mode. So first for the diagnostics and now for the planning. And this is when we start to think about a number of questions of need for grafting and how much of it, how many implants, how are we going to position them, what are the length and the width of the implants that we're going to use, and also to use it as a tool, a communication tool between the surgeon and the restorative dentist. So if we go back to the patient that we talked about earlier, post-accident and loss of anterior teeth, we know that we have a significant bone defect and inadequate for implant placement. So it gives us a precise idea of how much we need to graft. So for this, we're going to do an onlay graft. We're going to measure and harvest the precise amount of bone that we need to achieve the horizontal dimension that we're looking for. This onlay graft is harvested, modified, and adapted to the recipient site. And now we can really see how the implant foundation or the site is being developed, where we can ideally position the implant guided by where the restoration is going to be, and we will have a good stabilization as well as coverage. So here's the onlay graft. The space in between was grafted with particulate bone, covered with a GTR membrane, also used platelet-derived growth factor, and achieving a tensionless closure at the end. This is allowed to heal for about 6 months, and then we will use a new CT and a new guide to drive the implant placement. So another critical information that we get from our planning and the CT-guided planning is the number of implants. So here's a patient completely edentulous who has been using a denture for a number of years. The ridge appears to be reasonably good until we take a scan. And we quickly realize that there's a significant defect on the maxilla. We have severe pneumatization of the sinuses bilaterally, and in the premaxilla, we have some bone, but certainly limited in quantity. So we're going to, as a part of the planning, before even we present a treatment plan to a patient, before even we tell them what is possible, we're going to take this scan, we're going to do some virtual implant placement, just to get an idea of what is possible. So we're going to, place some virtual implants in our scan, and to get a feeling or get an assessment of how many implants are possible, what are the lengths that may be able to use, what are the widths that we might be able to use, and whether or not we can accomplish this without any bone grafting. So this is just all during the planning phase. Here is the 3D in different views, showing that what we were able to accomplish is 3 implants in the anterior and 2 implants in a distalized fashion to create a expanded or a good AP spread, and that this would be possible. So from here, we can speak to the patient and provide them with an idea of what is possible and what can be done. At the same time, we can see the precise implant diameters and the lengths that we're going to be using. This is communicated to the restorative dentist and the prosthodontist. Based on these information, they're going to start to plan and design the prostheses that would be suitable for this number of implants and this configuration. The next very obvious benefit during the planning of our implant cases using CT-guided approach is to avoid this kind of problem. The placement of there's no reason nowadays to have any implants not perfectly placed to receive a restoration and to achieve the kind of results that we're looking for. So there's absolutely no excuse for it, and nowadays, especially with use of surgical guides as well as the information we get from these scans, because we're looking for something like this: well-spaced, well-positioned, well-aligned implants, and this really makes not only the job of the restorative dentist easy, it makes the restorations normal, contours, easy to clean. It'll look great, and it'll certainly add longevity and long-term results. And this is what we're looking for. The last real benefit of the CT-guided planning is the actual surgical guide. This is when we translate all this information that we have learned from the diagnostics and from the planning phase, and now we're going to actually be able to translate that information and make it happen in the operating room. The placement of the implants, angulation, depth, and this is critical because we all realize that this is prosthetic-based dentistry, as we all have heard, and we need to follow prosthetic-based principles and restorations that we're trying to achieve to position our implants. So the common scenario that we use is initially have a radiographic stent or a radiographic guide made. This can be made typically from either a wax-up or from a patient's existing transitional restoration. Then we'll do our CBCT. Then we'll do our 3D planning, and from there we fabricate a guide. And this is very much a common scenario that we follow on many cases, and it makes the planning and the delivery of the results more predictable. Let's look at a case. Here's a patient with tooth number 9 that was extracted, and she was using a removable flipper at the time when we saw her. The first thing that was done, the prosthodontist provisionalized her. Teeth number 8 and 10 had existing crowns that were defective and needed to be replaced regardless. So those were removed, and the patient was provisionalized with a terrific temporary restoration. I emphasize a lot to the doctors I work with about fabricating a provisional restoration that looks and resembles the final prosthesis as much as possible, because this really provides us with the path and a prototype of what we're trying to accomplish. So having a provisional restoration this good will provide us with the understanding of where we're going. So in this particular patient, although the ridge looked reasonably well, there was some moderate horizontal bone loss and shrinkage, and this required grafting, not only to create a better implant site, but also to create a better tissue topography. So the grafting is used in this case for both purposes. So here we're going to do an onlay graft to provide us with a better buccal projection, and a ramus bone used to do a horizontal augmentation, additional particulate bone graft placed around the onlay graft, covered with a resorbable membrane, and ultimately closed. At this point, the patient is placed back into the provisional restoration, and this is the appearance at about 2 weeks as the tissues continue to mature. Yes. And ultimately, we keep the patient in the provisional restoration, and at this point, this is a 6-month period where we have a good tissue regeneration, and now we're ready to proceed with the implant. So we're going to use our radiographic stent that was made from the provisional restoration. It was duplicated, and we're going to scan it. And now we can precisely see that we have an alignment between the crown, where the bone is, and also the slight amount of undercut. And we're going to negotiate the position of the implant exactly where we need it. We finish our 3D planning, and from here we can fabricate our surgical guide. Here is on the day of surgery. The fixation screws are removed. Our tooth-borne guide is placed, and we're going to prepare the site exactly as we predicted on the 3D images. The implant is placed and allowed to heal for about 3 months in this case. Then it's provisionalized one more time for about 3 months in order to design the soft tissue. There's no question that this could have been immediately provisionalized and loaded, especially since we have the adjacent teeth to support the provisional. But ultimately, here's the final result with good outcome. As shown. The other case that we were talking about earlier, the patient with the complete upper missing teeth and significant loss of bone. What we established through the planning is that we can place 5 implants. So here we're going to do a dual scan. We're going to take the prosthesis and mark it and scan it by itself, and also scan it while the patient is wearing it. For this, we can use a very easy technique. There are these markers called shore mark that we can place right on the patient's existing denture. We place a number of them on the outside and also on the palatal aspect in various planes, and that allows the matching of the scans and relates the scan appliance to the patient scan. And then we're going to go and proceed with our implant position as discussed earlier, and ultimately create our surgical guide. Now this is a tissue-borne surgical guide. Because of the fact that there was limited zone of keratinized gingiva, a crystal incision was done in order to preserve as much keratinized gingiva as possible. And then the guide was placed and stabilized with hold-in pins. The implants are placed according to the trajectory and the depth as determined earlier. And the patient's denture was then converted on the same day. These are the posts on universal abutments. The denture is modified and luted to the posts. Occlusion is verified and finally screwed to the implant so the patient leaves home on the same day with a fixed prosthesis. We allowed the implant to heal for about 4 months, and then a fixed hybrid prosthesis, a final prosthesis, is fabricated. And here is the implant in position right after the placement. Again, to come to a close here, I think that what this technology and this approach has allowed us to do is to primarily deliver the aesthetics and the function that we're looking for, as well as long-term results, because we know more. We have better idea of what we're doing, and with more accuracy, and also primarily avoiding patient injury, failures, and other things that can happen from a lack of better vision. Thank you. If anyone of the audience wants additional resources from our office, feel free to go to our website, facialart.com/VuMedi, and complete a short form. I'll be happy to include you in our mailings. And also our website, there is a doctor section only that can provide some relevant information, videos, case reports for you to look at. Thank you again, and I appreciate your time. Thank you.